Hi, I'm Maggie Lauken. I'm a nurse practitioner student at Maryville University, and I'm going to be doing my head-to-toe assessment on my 46-year-old male patient, Dave, who has volunteered for me today. Before we started his assessment, he emptied his bladder. We did a full set of vital signs on him, including his height and weight. We checked his distance visions with the Snellen chart, as well as his near vision with the Rosenbaum chart. First, I'm going to be starting from top to bottom, and we're going to be checking his cranial nerves throughout. So looking at Dave's head, I'm going to start with just looking and inspecting his scalp. I'm looking for any nodules or lesions, cuts, scrapes, bruises, things like that that might be out of the ordinary. We're looking for any masses that might be on his skull as well. If Dave had hair, we would also document the color, texture of his hair and scalp. We're going to just kind of move down. We're going to look at Dave's eyes and face. Let's just check some of your facial, the cranial nerve number 7. I'm going to have you raise your eyebrows and lower them, frown, puff your cheeks out. Good. And squint your eyes really tight. Good. Okay, I'm going to check his temporomandibular joint. I'm going to have you just clench your teeth. I'm checking for muscle strength and symmetry, and that's fine as well. Looking at Dave's eyes, we're going to use the ophthalmoscope first. We're noting that his eyebrows are coarse and they extend to the outer canthus on both sides. His eyes are not reddened, there's no drainage, there's no lesions around them. I'm going to palpate his lacrimal apparatus, just noting that there's no edema and there's no xanthelasma. I'm going to use the ophthalmoscope, and we're going to look for the red reflex in the back of his eye. So just look straight ahead, Dave. And I see it. And in his other eye. And I see it there too. I'm going to check Dave's cranial nerves 3, 4, and 6, and that is the oculomotor, the trochlear, and the abducens. I'm going to use my otoscope for this, and we're checking for pupillary dilation, and we'll be checking his 6 cardinal fields of gaze. Again, one more time. And his pupils are equal, round, and reactive to light, so that's good. His sclera is white. As I pull his lower lid down, his conjunctiva is pink and moist. There's no signs of hemorrhage, so all of those are good findings. The 6 cardinal fields of gaze are next. I'm just going to have you follow my otoscope up and around, just looking at his eye movement, that it's smooth and symmetric, and that he accommodates as well, and all of that is intact. Next, I'm going to do the cover-uncover test. I'm just going to have you cover your left eye while I cover my right. Go ahead. You cover your left while I cover my right. I want you to, your right and my left. Just tell me when you see my wiggling fingers.
Oh, see him.
In the sign of sight. Good. So your periphery is intact. We're going to do your other eye.
Yep.
Good.
See him.
Good. Thank you.
Sorry.
That's okay. I'm going to go on to Dave's ears, and I'm going to use my otoscope again, noting the outside of his ears. Both are symmetrical. There's no redness. There's no drainage. And when I pull on the pinna, is there any tenderness?
Nope.
Good. So now I'm going to look inside his ear. And as I look, I can see the tympanic membrane. I can see the bony prominences behind. The cone of light is at about a 5 o'clock. This is his right ear. The ear canal is without redness. There's no edema. There's no pain when I look inside there. I'm going to look in his other ear as well. Any pain when I pull on the pinna?
Nope.
Good. And I'm just going to look inside. Again, mild cerumen. The cone of light is at 7 o'clock. The tympanic membrane is pearly gray. I can see the bony prominences, the bony landmarks behind the translucent membrane. His ears all look good. Now we're going to check for his hearing. We've got a couple of tests that we're going to do for that. First, I'm going to go behind Dave and I'm going to do the whisper test. And all I want you to do is repeat the words that I say.
Seven.
Oh.
Hamburger.
Good. All right. So the whisper test, he was able to hear me from 5 feet away. The next one, I'm going to strike the tuning fork and I'm going to perform the Weber test. I just want to know if you hear this in one ear greater than the other. I'm going to put it on the top of his head. The same or?
Both.
Both, good. So the Weber test has no negative findings. The next one is the Renee test or the Rhine test. And I'm going to strike the tuning fork again. I'm going to place it on his mastoid process. And when he no longer hears it, I'm going to put it out here beside his ear. And we're going to check and see if bone conduction or air conduction are greater.
Okay. Okay.
Good. His air conduction in his right ear was greater than bone conduction. We're checking the other side. That is an expected finding.
Okay. Okay.
So air conduction was about twice as long as bone conduction, which is what we would expect. So thank you. We're going to check Dave's nostrils. Can you just breathe in and out of each nostril separately? About the same. So his nostrils are patent. I'm going to look into his nares. And I'm noting that the turbines are, and the mucosal membrane is pink and moist. And there's no edema, no redness, no lesions. Thank you. We're not going to check his first cranial nerve, which is olfactory, and that would be his sense of smell. As I continue to look at Dave's face, his mouth, his lips are symmetric. There's no fissures, no cracks, no drainage, no lesions on his lips or the outside of his mouth. We're going to take a look inside your mouth. I'm just going to have you open wide. First, I'm just inspecting his teeth. I'm checking his mucous membranes. I would note how many teeth he has. Dave has 32. I would note the color. I would note if there's any crowns, fillings, chips, anything like that. I see none. I'm just going to use my tongue blade, Dave, and I'm just going to move your tongue side to side. I'm just looking underneath it for any lesions, looking in his cheeks, and that all looks good. The next thing I'm going to have you do is just open really wide so I can see the back. Can you stick your tongue out? Good. I'm just going to hold your tongue down just for a second. Good. I'm looking to make sure that his oropharynx is just pink and moist, free of lesions, which it is. Dave has no tonsils, but had he tonsils, I would also note the grade of those tonsils being 1 to 4. We're not going to check his nerve number 9, which would be his sense of taste. But we are going to do nerve number 12, so I'm just going to have you stick your tongue out and up and down and side to side, and that's cranial nerve number 12, the hypoglossal nerve, and that is intact. Let's go on and we will check, palpate his nodes. We're going to start at the base of his head with the occipital nodes, go to the post-auricular nodes, the pre-auricular nodes. Down under his chin, we're going to feel for his tonsillar, his submandibular, and his submental. I feel none of those. I'm going to go ahead and we're going to feel his supraclavicular. I feel none of his nodes. These are all expected findings. We're going to go down his neck and feel his anterior cervical nodes and his posterior cervical nodes, and I feel none of those. I'm just going to have you go ahead and lift your arms, and I'm just going to feel for any axillary or infraclavicular nodes, and I feel none. So all of his nodes are within normal limits. Dave, I'm just going to palpate your carotids one at a time. Good. Good. And can you look up? I'm going to just feel for your thyroid, and can you swallow? Good. His trachea is midline. The thyroid is mobile. There's no pain. And let's see. I'm going to have you lean forward. And I'm looking for any jugular vein distension, which there is none. If there were some, you can sit back up. I would also note, I would measure that. I'm going to listen with the bell of my stethoscope. Also, I'm going to listen to his carotid arteries. I hear no bruits. I'm also going to listen to your thyroid. And no bruits there as well. So those are all expected findings. Dave, I'm going to have you, do you mind taking off your shirt? I'm going to have you turn around. Let's start with your posterior chest. So do you mind sitting on the bed? That might be easier for you. Or for me, maybe. As I look at Dave's posterior chest, I am just looking for his breathing, which is even and regular. He's not short of breath. He's not in any distress. I'm going to put my hands on his back and have him take a nice deep breath in and out. And I notice that my hands are moving evenly. So those are all good findings. I'm going to percuss. I'm listening for tympany across those lung fields. And that's good. I'm going to have you say 99, Dave.
99, 99,
And
99,
I'm feeling in his costovertebral
99,
angles,
99.
or his intercostal spaces, thank you, for any tactile phrenitis, which I do hear throughout, which is an expected finding. Now I'm going to auscultate his lungs. I'm going to be comparing right to left. Nice deep breath in and out. With each breath, again, comparing right to left. I'm going to do his lateral aspects of his lungs as well, comparing them. I hear no adventitious lung sounds. I don't hear any crackles, no wheezes, no rubs. Those are all good findings. Next, Dave, I'm just going to have you take a deep breath in, and I'm going to percuss down until I no longer hear tympany. And I'm going to mark that. Oops. And again, breathe in. I'm going to do the right side. We're just measuring his diaphragmatic excursion. Okay, breathe normal. Then I'm going to have you take a deep breath and blow it out. And hold it. Good. Mark that. Sorry. And hold it and mark that. We are going to measure the diaphragmatic excursion, which should be between 3 and 5 on each side. And Dave is right around 4. It's a little bit higher on the right side versus the left, and that's because of the placement of his liver. I'm going to have you go ahead and turn around. We're still just inspecting his breathing, his chest wall. We're looking for any nodules, masses, any heaves or lifts as we look at him. And I see none. He's not in any distress. We're going to feel for tactile phrenitis as well. So go ahead and say 99 again.
99, 99, 99, 99.
And we can feel that throughout. That's an expected finding. I'm going to percuss over his entire lung field, and I'm just listening for tympany. When I get in that precordium area, I do feel dullness, and that's because his heart is right behind there. All right, I'm going to listen to his lungs. Again, comparing right to left, starting at the top. With each breath, I'm just listening for any adventitious lung sounds. Some of those lung sounds would be wheezes, crackles, or rubs. And I hear none. And those are all expected findings. Next, I'm going to listen to his heart sounds. We're going to, actually let me just explain what we're going to do. At the base of his heart, I would feel for any lifts or thrills on both sides, the left and the right side of the precordium, as well down below at the apex, I would feel for the apical pulse. All right, now let's listen in all those same places and listen to his heart sounds. The aortic, the pulmonic, down here at Erb's point, the tricuspid area, and the mitral. And as I listen to the mitral sound, the S1, I'm also going to palpate his carotid, and this should line up and be the same beat, which it is. Good. Thank you. All right. I'm going to have you go ahead and lay down, Dave. And I'm inspecting his abdomen. I would look at his abdomen for any, I would look for any breathing, make sure that everything is smooth and symmetrical. I would look for any masses or nodules, areas of concern that might be a hernia or something like that. As I inspect, the next thing that I do when I do the abdominal part of the assessment is I auscultate first, and I'm going to start in his right lower quadrant. I'll listen for a full minute in each quadrant, moving from the right lower to right upper, across to the left upper, and I'll finish in the left lower quadrant. Again, listening for a full minute, I hear that his bowel sounds are normal active, meaning that there's between 5 and 35 clicks in a full minute, gurgles, squeaks, different intestinal sounds. So those are all good findings. Next, I'm going to use light, actually let me percuss before I do palpation, and I'm just going to listen for tympany across his entire abdomen. The stomach and the intestines all should be tympanic. When I get over the organs such as the liver, I hear dullness, and the spleen, I'm going to percuss for those areas too of dullness. So I'm just going to percuss the liver borders here first, Dave. So I'm going to go down the mid-clavicular coastal angle on his right side, and I'm just going to percuss on his thoracic area until I hear dullness. We're going to mark that. And then I'm going to go from his umbilicus up, again listening for the tympany to change to dullness, and I'll mark that as well. When we measure that out, it's usually between 6 and 12, and Dave is right about 7.5, and so that's an expected finding for his liver. I'm going to have you roll just on your left side there, Dave, just so that I can percuss your spleen. That's good, just like that. And I can hear the dullness of the spleen. All right, you can lay back on your back. I'm going to do the light palpation now. And the light palpation just helps Dave's body kind of get used to my hands touching him. And we're looking at his face for any wincing, meaning that he might have pain. And Dave appears to be doing fine. Any abdominal pain? Good. Now I'm going to use some deep palpation. And again, you're watching your patient's face for any pain or wincing signs. And you ask them, any pain?
No pain.
Good. All right, so his deep palpation was good. I'm going to palpate both of his kidneys. So I'm just going to put one hand underneath you and palpate for a kidney there, and over onto your right side for your kidney there. I'm going to do some deep palpation and feel for your liver border. And we've got that, and we're going to palpate and see if we can find that spleen, but Dave is healthy and I cannot palpate his spleen, so those are all good findings. The last part of the auscultation on his abdomen that I'm going to do is I'm going to listen to the aortic and the other abdominal arteries. So with the bell of my stethoscope, just to the left of his umbilicus, I'm going to listen for his aortic artery. I'm going to listen to his renal artery on the left, his renal artery on the right, his iliac artery on the left, and compare it to on the right, and finally his femoral artery on the left, and his femoral artery on the right. I'm also going to note that there was no abdominal muscle separation, and he has no pain. So I'm going to have you go ahead and sit up. And we are going to check his muscle strength in his extremities as well as sensation. So I'm going to start with your arms. I just want you to squeeze my fingers and push me. I think I did this already. And pull me. Good. And then I'm going to do your legs. I'm noting hair distribution on his legs and the muscle strength or atrophy, and Dave's muscles look just fine. I'm going to palpate his arteries. Actually, I'm going to have you lay down so that the camera can see me do this, just so that I can do your legs. I'm going to palpate his arteries, his popliteal, which is behind his knee, and bilaterally, his posterior trochlear, and his dorsalis pedis. And all of those are a 2+ expected finding, so thank you. I'm going to check his Achilles reflex. Good. I'm going to have you sit up. I'm going to do your patellar reflex. Good. And your brachial. Just relax. Good. Bilaterally. Good. I'm going to also check your pulses in your wrists, your radial pulse, and your brachial pulse. Good. All 2+ expected finding. Lastly, I'm going to have you go ahead and stand up and turn sideways. I'm looking at his back for any S or C curves, making sure that he's got full range of motion. Can you just bend over a little bit? Good. He's got range of motion there. I'm going to have you stand up straight. There's no signs of scoliosis. His spine is in line. Can you tilt side to side? Can you turn side to side? Good, thank you. And can you squat a little bit? Good. Any pain with any of that?
Nope.
Good, so his range of motion in all of his extremities, can you put your hands overhead? Good. His range of motion in all extremities is intact. And I'm going to have you walk across the room. I'm looking for symmetry and stride, for arm swing, and just making sure that he's not in any pain as he does that. Good. How are you feeling?
Feel great.
Good. I'm going to check in your extremities for the sensation as well, and we're just going to check for both pain and sensation. So it won't be too much pain though, because I just have a cotton swab and the dull end of the cotton swab. So the soft end and the dull end. I'm just going to check your extremities. You just close your eyes and tell me where you feel it and if it's dull or sharp.
Dull in my bicep. Sharp in my calf muscle.
Mm-hmm.
Soft down my thigh.
Good.
Sharp in my bicep.
Yep. And we're going to do your trigeminal nerves. This is nerve number 5, and it's in his face. So I just want to see, do you feel this on both sides evenly?
Yes.
Good. And tell me sharp or dull?
Dull. Sharp. Dull. Dull.
Good. All right. That was my head to toe assessment. Thank you for watching, and I appreciate it.